This is making healthcare better and reducing readmission rates through hospitalist technology and communication. Florida ranks as one of the highest states in readmission rates in the nation. And in this presentation, we're going to gain better understanding of how we can rectify the problem and make healthcare better for all by using hospitalist technology and better communication. Dr. Nagda will show you how proper implementation of these processes is reducing the admission rates for optimizing transitional care between hospitals, skilled nursing facilities, and primary care physicians. And to help moderate, we have Michelle Pribble that is going to be asking all the questions, and she's also from CFIM, so take it away, Michelle.
Thank you. All right, good morning. Thanks so much, Dorothy. That was a great introduction about what we're going to be talking about today. In addition to Dr. Nagda, who is the CEO of Central Florida Inpatient Medicine and who has reduced readmissions to less than 10% between acute, post-acute, which means hospitals, skilled nursing facilities, and PCP offices. We also have guest Kara, who is the Senior Vice President of Business Development for Consulate Healthcare, which is the largest skilled nursing provider in Florida aimed at transforming skilled nursing to improve the care and experience of individuals they serve. She's recognized as a thought leader in transitional care, having previously developed a care coordination program to reduce readmissions. Kara Plaks has experience leading BIPSI Model 3 and working with ACOs focused on improving post-acute integration to better meet the goals of healthcare systems. We also have Patrick Chunn, who is the CEO, CFO of Golden Health ACO. He has over 30 years of healthcare experience as an owner, operator, and C-level executive of several successful healthcare organizations. As the CEO of Golden Health, he provides strategic leadership with several corporate ancillary providers and vendor relationships, our board of directors and various subcommittees and capital partners. He's also responsible for finance and accounting, financial planning and analysis, and corporate reporting. He has held positions which has helped organizations ranging in size from startups to over $1 billion in annual revenue, including Patient Matters, Hospital Physician Partners, Independent Living Systems, MHM Services, and Vista Health Plans. So thank you all for joining us this morning. As we talk about the cost of healthcare and how it's been escalating over the past several years, in 2008, just to give you some background, healthcare expenditures surpassed $2.3 trillion, and all current trends seem to indicate that that will continue, which it has. And some of the reasons or some of the significant drivers for that is because of coordination or lack of coordination of services among health providers, which you'll hear today some solutions that our leaders have had, and medical treatment, clinical variation, and costly medical errors. With over 150 Florida hospitals with readmission penalties from CMS for fiscal year of 2016, over 70% had a higher penalty in 2016 compared to the prior year. So I'm going to go ahead and open up the discussion. I just want to ask each of you a few questions. So we'll start with Kara Plaks, so you're there on the end. Can you just share with us who is Consulate Healthcare?
Sure. Consulate Healthcare, we have 180 skilled nursing centers throughout the country. We also have some assisted living and independent living. And, you know, I think the history of skilled nursing centers has mostly been long-term, and the views on skilled nursing centers not always so great. But we are really transforming what skilled nursing centers do around care coordination, clinical pathways, you know, coordinating care to get more and more patients home. So some patients come for short term and some patients also stay for long term, but really transforming what we do within our communities.
Great, thank you. And how has the healthcare transformation from value to value impacted skilled nursing centers?
Sure. So, you know, really for skilled nursing centers, it has to change as the transformation of healthcare as we go from this volume to value. What do skilled nursing centers do? And so a couple things have been happening. There's a whole utilization shift of care. So a lot of the patients that we used to get are actually going home with home health. So we have to really look at taking higher complexity patients, higher clinical that we're able to take, and then also just a culture change on how do we fit into the changes that are happening within within the healthcare organizations and really partnering where we used to be very siloed. We are now really partnering with hospitals. We're partnering with home health. How do we coordinate care along the continuum of care?
That's awesome. And then what is Consulate doing? What is your team doing to be a value-based partner within these communities? I know you just shared a few.
Sure, yeah, and you know, it's really around the care coordination is our biggest opportunity, and when we talk specifically about reducing readmissions, it's getting our teams and the culture changed so that everybody is looking for small changes in conditions as we have patients. So it used to be that, you know, when a patient had a decline, then we would talk about the patient going to the hospital, but now we are actually training all of our staff, dietary, housekeeping, nurses, that to look for small changes in conditions. So one of the culture changes, we have housekeepers who can go in and say, you know what, Mr. Jones isn't talking to me as much as he usually does, and we're able to go in and actually you know, make some changes with that patient prior. The other thing is getting patients involved with their own health care, so patient engagement on self-management skills. We're not just taking care of the patient while they're there, but we're helping them understand their medication and what got them in the hospital to begin with, and the yellow flags of their diagnosis, what may happen, what they're going to do when they go home, how do they set up an appointment with primary care physician. Really getting patients engaged in their own health care is another opportunity that we're doing.
Awesome. Thank you so much for sharing that.
Pleasure.
Dr. Nagda, can you share with us a little bit about CFIM and when you first identified that there was an opportunity with care coordination and hospitalist care?
So just a little background on CFIM. We started out purely as a hospitalist company back in 2001, serving Florida Hospital. Shortly thereafter, we expanded into multiple hospital systems, covering about 14 hospitals across the Tri-County. As we realized with the movement of the hospitalist, currently we are about 135 providers. When the Affordable Care Act came in, we realized that one of the things we needed to do was really look at the full spectrum, the integrated healthcare delivery model. There are a lot of gaps, specifically in the transition from the outpatient to the inpatient, from the inpatient to the outpatient. So again, there's as Kara said, typically healthcare has been in silo. Everybody looks at what's just important to them. There's lack of communication, there's a lack of discussion of this is going on from A to B. So one of our goals was how do we bridge this between the different silos. A few years ago, before the penalties for CMS imposed on readmissions or value-based, hospitals basically were like, okay, the patient's out of my door, I don't really care about this, what happens to that patient. And the way the healthcare system is, still currently is there's really not an incentive to drive those readmissions down. Readmissions, when we look at this, are pretty much anywhere from about 10 to 15% of added cost. So it's similar to if you look at just in our day-to-day, you take your car to a mechanic, 15% of the time you're going to have to bring that car back in 30 days. I don't know, are we going to be happy with, you know what, I took my car, there was a transmission problem, you fixed it, now there's something else, or now there's something related to the transmission again? In every asset of any type of companies, any type of service line, that's something just unacceptable. And we've accepted that just, well, you know what, the human body is very complex. So when we're talking about these complex issues, there's going to be some of that coming back. We may not identify the problem the first time. It's not really that the human body is complex. It's there really is not a continuous care delivery in between the healthcare providers. There's not on the patient side, and then there's not on the caregiver side in terms of the healthcare side of things. So one of the things we looked at was how do we bridge that? So one solution obviously was just our group providing care in multiple settings. So we started with a hospitalist about 8 to 9 years ago. Florida Hospital asked us to do nursing homes. So at the request of Florida Hospital, we said, okay, we'll do nursing homes. not really fully, wholeheartedly. It was just something the hospital wanted. Let's just go ahead and do it because they're seeing a lot of bounce back between inter-facilities and a lot of things that they're not getting paid for. As value-based came in, we realized that's another area where we have to actually make it a service line. We transitioned then to the outpatient side where we're doing transition visits. And again, at these points, we wanted to have not only is our provider there, but how do we share data? A simple document. Give me the list of medications. Give me what's the next thing you need to do? What's the follow-up? Well, who's going to do the follow-up? When is that follow-up going to be? The medication, and then tell me if there's an issue, what are you going to do about it? Either the patient or somebody who's providing that. So the technology piece came into it. And I'll stop there because I can ramble on.
Well, no, I mean, that goes into my next question. I mean, in terms of communication throughout the entire continuum, and kind of like you were talking about bridging the gap between each of the entities, how have you found the technology is helping with that process? Because I know CFIM has a technology communication portal.
Well, I think the technology is helping with that, but technology itself is not a solution. We have to look at the entire spectrum of things in terms of how things are. So there has to be a continuum in terms of communication between providers. The technology can help, but we need to look at the process. I'll give you a very simple, and again, I want to make sure that I don't go either too detail into it or too superficial. So I'm assuming a lot of, how many healthcare providers or from the provider side do we have here? So this table should be all raising their hands too. All provider side. So we've got a lot of provider side. So when we look at the technology, it's an enabler. But ultimately, we have to look at the relationships. So when we start looking at readmission, okay, we identify that is a problem that we can have, that there are some solutions out there. Number one is medication reconciliation, or what medication should be on, the patient should be on. If you look at what happens, and I'll just kind of walk you through the cycle of a patient coming in from the outpatient. And this is a typical patient, Medicare patient, 65, 70 years old, comes into the hospital. They have a list of medications that they brought in. The hospital changes those medications based on their formulary. So a medication such as something that is for heart rate might get switched to something that might be for heart rate and blood pressure. Now that patient has a new medication in the hospital. Why? Because that wasn't the primary issue. They came in for a pneumonia, getting IV antibiotics, but they also have diabetes, high blood pressure, high cholesterol. So now some of those medications get switched. When they go home, again, a med reconciliation happens. The hospitalist may decide to go, oh, you know what? I'll switch them back to their home meds and stop this medication. But now look at the chance of error. I've got two medications, so somebody has to make a decision of which one to stop, which one to continue, and sometimes they just say continue the current medication, give them a prescription. And they tell them patients, hey, please stop your previous medication. Patient goes home, just like a good patient, they go to the pharmacy, here's my 4 scripts, fills it. Now they've got in the medicine cabinet 8 medications. Simply, they just don't have the knowledge of which one to stop, which one not to stop. So that's probably 50 to 60% of our readmissions from the hospital to the back to from outpatient could be if we just have a med reconciliation process. And so how do we do that? Well, you have to have technology. I need to know the list of my medications within 24 hours. So I need to have a discharge summary available, whether it's a primary care doctor doing it or someone else doing it. So we've created a transition care from the hospital to the nurse, to the outpatient. Get us a list of medication, we'll make a call 24 to 48 hours just to, hey, let's go over your medication. Bring all the pills out there, tell me the name, and I'll go through and I'll tell you what you should do. And just a 15-minute call to do that piece. Same thing now, again, when we look at this piece, I think we've made a lot of effort in discharges from the hospital to outpatient and readmission, where the next piece that we're looking at is on the nursing homes. I was surprised to find that the skilled nursing, and again, the skilled nursing readmissions post-discharge are as high or even now higher than the post-hospital. So really we're looking at patients who are sicker. Typically hospital patients should be sicker than a patient coming out of a skilled nursing, because they've come from the skilled hospital to skilled nursing, stayed 15, 20, 25 days. Patrick would like 7, but we'll talk about that later. But when they go into that nursing home, again, why is that? Same thing. We don't have right now, and again, this is where we partnered with Consulate, who've said, look, 186 buildings, they're the largest provider in the state. They said, we don't want to be the biggest. We want to be the best. What can we do to improve quality, not just in one building, but across? So as we looked at that, we said, you know what, let's create some of these things. So one of the pilots that we're talking to them about is every discharge, please call the provider. This will be shocking to you, but in most nursing homes, the person who does the discharge, social worker. Of the state regulation, I have to see a patient in the nursing home one time in 30 days. One time in 30 days. These are patients, as Kara said, the value-based has pushed patients to the next alternative setting. So we used to have patients in the hospital for many days and days and days, but no longer. A blood clot that used to be 3 to 5 days now is an outpatient completely. Give them a blood thinner, have them go see the outpatient. So these patients who are coming into our skilled setting are sicker. And patients who are now going to ALF are sicker than before. So we've just moved patients downstream to sicker patients, more higher acuity, into places where typically we've not asked to do that type of care. So as we look at that, it is looking at integrations and doing some of these projects of just a simple phone call. If I saw the patient Tuesday, the health plan says, well, the patient must be discharged on Friday. Call me on Friday and let's do a med reconciliation. What are the medications I want you to go? What's the follow-up? Just tell me, do you have a follow-up? Average wait time for primary care doctors in Orlando, 19 days. So if I tell you, from the ER doctor says, go see your PCP. If you call your PCP, the average PCP will say, okay, I'll see you in 19 days. That's where we have to create not only technology and process. How do I fill that gap? Maybe I need to come see you one time at your house. Maybe you need to come to a transition clinic just for once to make sure that 19 days is too long. And one of the things we measure is a 7-day readmission. Because that 7-day readmission tells us that we did something wrong in terms of communication, teaching, medication reconciliation, because patients should not come back within 7 days. Now there's some disease states they will, but not 8%, 10%. If they come in 30 days, well, that's just, again, patients with CHF have high frequent readmissions. But so as we look at the process, technology is just one piece.
Awesome. Thank you so much, Dr.
I think I
Nagda.
covered my talk.
It's okay. Okay, and on to Mr. Patrick Chunn with Golden Health ACO. If you could just share with us a little bit about the company, and as healthcare has shifted to value-based care versus fee-for-service, can you also share with us when you've identified that there was an opportunity with care coordination?
Sure. Good morning, everyone. Golden Health is a relatively new organization. In fact, we're waiting on our approval from CMS to participate in the Next Generation ACO program on January 1st. Our organization is new, but myself and my management team have been around the Florida managed care space for a long, long time. In terms of, and my perspective will obviously be different from the other two presenters because we're not a provider. I like to think of our role in healthcare as being a service organization. And I can just share some past experience where the light really went on for me. And it was not in an ACO environment, it was really before ACOs began. But in a former life, I was a CFO with a company called Independent Living Systems. And we participated in a program called the Nursing Home Diversion Program, which is a Florida Medicaid waiver program. And if you're familiar with that program, my story might resonate with you a bit. But I will remember the first time that the CEO came into my office and said, we are going to install an air conditioner in an elderly woman's home. And before you say anything, I'm just telling you, before this conversation's over, you're going to agree to do it. And by the way, the nursing home diversion program, for those of you that are not aware of that program, it's for frail and elderly folks that have gone through a clinical evaluation and they're at risk for nursing home placement. And the other twist is that they're poor, so they're dual eligibles. So they qualify for Medicaid. So you can imagine that the folks that we were serving were some of the most frail and poorest folks around. And so the CEO was right. We installed the air conditioner, and that was in 2001, and that person remained inside the nursing home diversion program for several years after that. So, you know, for me, what that says is that a couple of things. I think creativity is important. Some of what we've done historically has worked, some of what we've done historically hasn't worked. And I think the one thing I like about the ACO space is it is somewhat of a liberating healthcare space in that it affords us the ability to be able to be creative. And so while we're not providers, when we look at what we do and how we do it, our focus is generally on two things. One, it's provider engagement, and two, it's beneficiary engagement. And so some of the things that we do that are a little bit different than what you might find in a, say, a commercial or an MA managed care space, will deploy staff. And sometimes dedicate it to some of our larger practices. Now, you know, being a bean counter by trade, I want to be careful not to commit that we're going to pay for everything to everyone and be everything under the sun. It was interesting. So I was in a meeting earlier this week, and one of our larger physician practices was in a group setting with one of our IT vendors, and we were talking about our concept of deploying our what we call a care coordinator. A little bit of a misnomer, but we call them care coordinators inside our practices, and this practice is a large practice. So we've committed that one of our care coordinators will be dedicated to that practice every day. And so as we're walking through and talking about some of the workflow challenges, the practice administrator said, well, Patrick, that's a great idea, and I appreciate you committing resources to my company, but to accomplish all the things that we're talking about, I hope you're ready to deploy 20 people, because that's what it's going to take to be able to do it. So, you know, creativity is important. We need to be cost conscious about what we're deploying and to whom and where. But that being said, I think we've got the ability as an ACO to be able to, again, creatively deploy different initiatives that will combine. Another thing that Dr. Nagda said that resonated with me was that it's not just about technology. So, for example, in terms of beneficiary engagement, I'm very bullish on the concept of a call center, and I've seen these call centers work in a commercial environment, and I'm convinced that they can work effectively and efficiently in a Medicare environment. Obviously, we have to figure out as the ACO how we're going to pay for something like that, but I believe that, and I think the other limitation is that with regard to call centers in an MA or in a Medicare environment, there's not a lot of data to be able to connect, well, what are the positive outcomes that you can achieve with the call center? How will you reduce costs? How will you improve patient satisfaction? So unfortunately, there's not a lot of data that help us connect all of these points. But nonetheless, I think that is one strategy that we're looking at, again, in terms of being creative and working hand in hand with our providers to be able to improve the patient's journey through the healthcare delivery system, improve outcomes, improve quality, increase patient satisfaction, and lower costs all at the same time.
That's all great. So you brought up care coordination, having a care coordinator. How do you expect, or in your experience, how that has addressed and improved communication problems with your partners within the ACO realm?
So great question. We call the person a care coordinator. So interestingly, another comment that Dr. Nagda made was about social workers. The background of our care coordinators will be social work. And another example that I can use in the nursing home diversion program was that we did a care plan for every single person every single member that was in the plan. And those care plans were developed with clinical staff, but they were overseen and managed by social workers. And so what we found was that there's non-clinical factors, obviously, that come into play, and a lot of those are socioeconomic factors. And the social worker's background can assist in some of those areas. So while we call them social workers, really what we're trying to achieve is, number one, we're trying to create resources for the physicians' practices. And number two, they're really our eyes and ears inside the practice. And so while the social worker can be very good at handling socioeconomic issues and challenges, such as transportation, there are other areas that are probably more tilting toward the clinical side, and so they'll need to lean on certain people within our organization. But nonetheless, we believe, and we've seen in the past in other ACO programs, where when we've got somebody that's rounding through the clinical practices daily or at least weekly, they'll hear a lot of challenges and issues. And so as they need to reach out to other people in our organization, whether it is our clinical folks when there's some type of a case management issue or a transitional care challenge, or whether it's our data analytics team to engage on population health or interpretation of the data and the information that we've got, that person can be there to reach out to the right person, and then we can engage and deploy some of our other folks.
Just, again, as Patrick mentioned, one of the things that, again, my engineer, I'm an engineer, ex-engineer, or actually a current engineer, so I think I'm more of an engineer than a doctor and a businessman, so, but my thought process is similar to what Patrick said. My goal is not to change the process. I look at a process and I say, how do we leverage the current resources? So again, when you look at readmissions, two factors that are really important is, number one, medication reconciliation, understanding medication. Second is the social, the social economic factor of caregivers, having the right location, the patients being there. So a lot of times we'll get patients who come to the hospital and say, what are you bringing? We just can't take care of mom or dad. So there are those components. If we focus in on those two components. So again, as we talked about the social work, again, I think this is a great resource to have. However, what we want to do there is just tie in with somebody who brings in that clinical aspect. So when you look at that process, right now, that social worker in the nursing home has to go in first, and again, I may be off, so again, I'm just having a limited experience, so Kara can jump in. I'll jump in if you correct me. But they have to, again, there's a position there that coordinates with the health plan to say, hey, how long do they need the skilled? Then they coordinate with family members and the patients to see what the needs are, transportations, all those things. And then they have to coordinate the appointments that need to be made, okay? So this one person has to do pretty much everything for that transition. And again, this is something that is a huge task. They're great at some of those factors of coordinating with the health plan, coordinating with the family about transportation, or making sure it's a safety. I mean, nursing homes will actually send people out there to the home and say, hey, is this patient safe at home? Can I send them to a home because their family wants home? And sometimes they have to say, no, this is not it's a safety issue. But where we want to add to that is the physician component. Again, of what can I do to help that social worker and bring that in? And our goal is to, again, I look at that process across the board. And my baseball analogy is not everybody can be the best. However, what we want to do is wrap processes in technology that allows them. We want to, there's a couple of 400 hitters. We've got some Consecos and A-Rods on our team, but then we have some 100 hitters and 200 hitters. Now what we want to do is bring that up So we want to add the support in every aspect of it. We're not competing with our PCP. We know that there's a reason they don't see the patient in 19 days. Why? Because A, they're slammed. B, that hospital patient is a much more complicated. Nursing home patients, they don't even know what happened to them. A patient had a CABG, stayed 10 days in the hospital, stayed 35 days in the nursing home. Now they call 45 days later saying, hey, I need to see an appointment. By the way, I have now 10 new medications. I don't know what happened. They could have had an infection. They could have had all these things. So that patient's going to take an hour for the primary care doctor. They don't get reimbursed for it. They don't have time for it. So that's where we want to say, you know what, how can we help you? How can we support you in this process, because we see the patient is lacking this. So every aspect of what we're talking about is not to bring in something new. It's how do we look at this process and say, where can we make an impact? One of the things we're doing is, again, Sandra's there with Cassie. We're doing a pilot with Sandra, as well as another home health company, where we're giving a patient all of our discharges, and I like to do this in the nursing home, one single number. You have an issue, you call this number. Inbound calls to this for the next 30 days, we will coordinate all the things that need to happen. We're adding a telemedicine component, so if that person, it's a social worker, who takes the initial call, if he or she feels it's a clinical, they escalate it to a nurse, that escalates to a physician. We can now do a telephonic intervention or a telemedicine intervention. I mean, if you look at where healthcare is today, we have patients, and again, I was talking to a physician whose family member went into the hospital, and they said, who do we call? This is a doctor. I'll give you my personal story. My mom has lots of medical issues, lung cancer multiple times. She had radiation, so she had 24 stents. 24 stents. So she's very complicated. COPD, half a lung, various other things. She's 74. She was in the hospital because she had an allergic reaction to an antibiotic. Full-blown anaphylaxis, completely, she needed to be in the hospital, get all the medication. Because of that reaction, she developed AFib, fast heart rate. So on Friday, she was there for 3 days. On Friday, the cardiologist wrote some medications and discharged her, and they went to the Walgreens. They got a call 3 hours later that says that the medication is not covered or authorized, and she needed to talk to the cardiologist. There was no cardiologist available till Monday. This is a few years back. I'm a doctor, so I said, no, I'll call it in, not a problem. But here's the thing is, if I'm not there, who does, and again, I knew who to call. I mean, I said, listen, I don't need to, I know what there is there, I'll give you a substitute, we'll cover this, we'll give you until 48 hours. Tuesday, we got a call back from the cardiology office. For routine calls, if you call your PCP, it says, if it's an emergency, call 911. If not, leave a message and we'll get back to you in business hours. That's medication. They just needed one medication, but here's the thing is, she just spent 3 days in the hospital. She doesn't get that medication, she'll probably go back into AFib again and back to the hospital. This is a very simple thing that a transition care phone call to say, hey, did you get your medications filled? And if not, why? It may be that they're not covered, it may be that the cost, but then again, somebody there who can say, you know what? We can get you to a cheaper medication. Or let me tell you what we can do. Don't go to the ER. Central Florida has the highest admission rate. I'm not sure if we've got anybody from the hospital here or not, but Central Florida has the highest admission rate from the ED, Orlando Health and Florida Hospital. If you end up in the ER, there is a good chance, higher chance that you will end up hospitalized in Orlando than in Miami, Jacksonville, Tampa. We have one of the higher national admission rates. Now, again, it's coming down. There's a lot of factors there, but one of the things we want to do is how do we get the resource to the patient? How do we then also get a resource on our clinical side? Whether it's a nursing home. Hospitals have it, but again, they have a 24-hour line, but it's not a physician who can actually make decisions. You know, if I ask Kara, say, okay, can you give somebody on your side who they can call? Sure, they can. But then if they need to change medication, if they need to do that, how do they get the partnership? And that's really what this is about. This is a very simple concept about if we have a relationship, the nursing home and the physician, the home health, the ALFs, the, all of the people who are there. And there simply is a simple phone call. Nursing home health companies, they go in, physical therapy, and they say, oh, what are you doing here? You should be in the hospital. You're too sick to do this. No, call me as a provider. Let's talk about it and let's figure out what we can do there. So it's really looking at what the system is and how do we add value to the system. Because again, the cost is something we have to consider. We cannot do this. The other piece we look at, 20% of the patients are eating up 80% of our cost. And if I showed you my readmissions from the hospitals, I have one patient who may have been there 7 admissions. Boom, 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 boom. Why? Because the hospital is where they get the care. They don't get it as an outpatient PCP's office or a clinic or somewhere. It's so easy for them to just call 911, 911 gets there. Again, if you have a patient who's complicated as my mom, and instead of me calling everybody, if she called, she would call 911 and just say, hey, I'm short of breath today. It's that piece of how do we give people resources so they take responsibility and engagement on the patient side.
And that's great because that really ties into the next question I have, and I want to open this up to all three of you. How are socioeconomic factors considered and managed during the patient outreach process? We've been talking about collaborating, communication, and how it's not just clinical. So if you could share with me what you think can help with that.
I can give you a local example if I'm okay to plug a local provider. So I did talk to the provider. They said that I could talk about them. So
perfect.
I love these kinds of stories. So when we're talking about beneficiary engagement, we talk about costs. You hear me talk about costs a lot, but in reality, there are some things that we can do that don't cost a lot of money. And so we've got a local cardiology practice. You probably know them. So the cardiologist started a year or so ago having monthly sessions for his patients, some of his patients, and very simple, basic presentations that talked about cardiac health. How do you achieve and maintain proper cardiac health? And in the control group, I think if I remember right, they were monitoring blood pressure control. So it was 64%. And the control group, which actually is not a bad metric, as I understand, nationally. For his patients that participated in I think they were hour-long sessions, over the course of a year, and they measured the compliance with blood pressure control, it was over 90%. I think it was 92% and change. That is a mammoth change. And then in addition, oh, by the way, the patient satisfaction scores increased as well. And so I think there's an example of, and that might not completely tie into socioeconomic, but what it does mean is that it wasn't. I don't want to underestimate the amount of time that it took for the cardiologist and his staff to do those sessions, but it wasn't something that was an expensive intervention. It really probably wasn't a lot of rocket science. They actually talked a little bit about what some of their sessions covered. But it was engaging the beneficiaries, it was talking to them, educating them, and as a result, their satisfaction levels went up, the compliance percentages went up, and there's a good example of, I think, how you can kind of creatively deploy resources to be able to improve the patient's experience as they maneuver through the healthcare delivery system.
That's great. That's a great example. And then I want to extend this to Kara, because I know you were sharing that you also have a program to help with care coordination and how that kind of ties into the socioeconomic space.
Sure. So the program that we have around care coordination is called the Journey Home, and that's really what it is how do we follow that patient from the hospital as they come to our center and going home. And I think a common theme today is collaboration and communication amongst the providers and keeping everybody up to date. We have several patients that come to us and their primary care physicians don't even know they went to the hospital, let alone that they are at one of our skilled nursing centers. So we do a lot on the front end on communication and talking with the primary care physicians. Medication reconciliation is absolutely something that we have to do on the front end. We also find out what the patient has at home. A lot of times the patient has all kinds of medicine in that medicine cabinet, you know, from years ago, and now new medication is being prescribed, and so making sure that they really understand that as they go home. And then as the patient is getting ready to go home, we actually have coaching sessions to help them understand, and I touched on this earlier, but to understand their medication, how they're going to take their medication, signs and symptoms that actually ended up getting them into the hospital in the first place, understanding the dietary changes, understanding all of that. And it's important for us to really partner with the hospital, with the physicians, with the home health on the patient education. So the patient's getting the same material and education from the hospital, from their physicians, from us, maybe from the ACO, the care navigator, and the patient is hearing the same message throughout the continuum of care. With those coaching sessions, we use something that's called teach-back strategies. I'm sure you all heard that or know about teach-back strategies, but it's really making sure that that patient understands what we're saying, having them repeat it back to us, talk about it, having more coaching sessions if they're having difficulty with that. And we're able to use that to communicate to the next care setting. If the patient is going home with home health or with the primary care physician, letting them know what we feel really good about with the patient going home, what they understand, and what our concerns are. You know, we sometimes hear that the patient doesn't end up going to the primary care physician, and the reason is they didn't have transportation. So making sure not only do we have a primary care physician appointment set up, but we confirm who's going to be taking that patient. It's amazing how many patients do not feel comfortable asking even their own loved ones. They feel like it's an inconvenience for people, so making sure that we are part of that. And then communicating as the patient goes home with the primary care physician, what we've done, what is still needed on the home health side, you know, what education still may be needed. And then also making sure that if the patient goes home with home health and the patient's not doing well, that we are an option for coming back. And part of that goes along with just educating people on what skilled nursing centers do and what we are capable of. We're able to take much higher complexity than we used to, so we're actually able to take patients who have changes in conditions at home and coming into our center. And we also know that, you know, there's you know, a lot of times we need an avoidance of skilled nursing center and getting them home because skilled nursing center, there's more of a cost than home. So we have a higher percentage of patients that we're seeing that used to come to us going straight home, but having that partnership with home health, that if a patient does go home with home health and is not doing well, we can take those patients in, and having you know, a direct admission program where the patient knows how quickly a physician will see them when they get to our center, starting that education and coaching right away on their self-management skills so that we can get them back home and into their community again.
That's great. A lot of programs going on to help everybody out in the community, putting that focus on the patient. I wanted to open the questions out to the audience. So I'm going to hand it off to Dorothy.
Yes, great information. Really appreciate all that. I think, Cassie, you had a question.
Good morning. Good morning. Thank you so much for sharing and all the knowledge. My question goes to Patrick. Patrick, I heard you say that the Next Gen ACO is the track that Golden Health has chosen. There's many different tracks. Why Next Gen?
One of the main reasons is that in the Next Gen program, there's a monthly funding mechanism called the population-based payment, and that creates a revenue stream for us to be able to deploy some of the things that we're talking about, and that's not available to the MSSP ACOs.
Well, I want to thank you all, first of all, because the Health Council of East Central Florida is involved in development of 2 new health delivery models, or should I say revision of 2. Seminole County, we operate the network for the uninsured in the county together with a variety of community providers. And in Osceola County, now we've been given the opportunity to re-examine how care is being delivered. Interestingly enough, I used to, when I was at Orlando Health, be known for resources destroy creativity. we don't have the resources. We're working with the uninsured in populations in both those counties. So I'm interested in ideas, maybe a crystal ball for a moment. What do you see and what might apply in those counties that would help where we don't have a lot of money to pour into the system?
So just my perspective on this is the underinsured, the self-pay, is one of the highest cost for a hospital system. So if you look at the systems in town, Orlando Health, Florida Hospital, and the HCA hospitals, and go to them and say, hey, listen, what's keeping you up at night? They will tell you my risk business, my Medicares, and my self-pays. They don't say United, Aetna, Cigna. That's just employers, Disney, that's there. But the big thing is that's a $100, $200, $300 million problem. We have talked to them about some opportunities of working together. This goes back to the social economic. If I can get this, if I can identify the patient and say, guys, you help, I'll go to the patient's house if they have a house. It's how do we bring, so there are some opportunities, and I think organizations like yours need to sit and say, there is money there. Florida, I mean, you ask anybody, again, Florida Hospital is a nonprofit, so that may not, same equation as an HCA, but there is money in the system that people will commit to say, if you can help reduce my ER visits by these self-pays, we will be happy to contribute X amount. I think there's some, the creativity has to be there in the healthcare. And my thing is I look at the money. Who has the money? Who's costing the money? Because that's the person I want to meet with and say, here's a solution that will help you. Because ultimately, that's hurting the whole system. Somebody's subsidizing it. So it's the federal government subsidizing it. It's us taxpayers. And so we can come up with these solutions to say, what can we do in Osceola for this patient population that is indigent? One of my biggest challenges is my self-pay. I can't find a clinic to see them, but that's where we started to partner, saying, I'll do a visit one time, just cover my cost. Again, we're looking at, as we look at this, and again, it has to be scale. It has to be scale-based, because one single organization that has 5 doctors or 5 providers cannot do this. But if I can have United, Aetna, Cigna, the employers, and the hospital all in one umbrella saying, guys, go do this. Part of doing this business, you got to also help me out with this patient population that you don't want to do it, higher resources, higher cost consumption. For you, it's not a profitable, but there's a piece there. It has to be the service. Again, it has to make business sense. Second thing is the service component, but I think there's opportunities.
And I think the creativity comes from us getting together, right? So we each see things a little bit differently. We all know that we have to do things differently, and it's these conversations that I always walk away with unique ideas or where the creativity really comes from. And at the end of the day, what it's really doing is making or having better outcomes and a better patient experience, because what we're doing is really for the patient.
We're going to sneak in one more quick question from Dr. Fez.
Good morning. Thank you guys for that excellent introduction to readmission rates. For non-medical professionals, I thought that was a great explanation. Dr. Ahmed and I, we're actually primary care physicians by trade, but we do locums hospitalists for ORMC and Team Health, just as locums, and we travel to different states. So we kind of have an inside perspective of readmission rates. And I was just wanting to ask, since we do outpatient, or our spouses do outpatient, and the average primary care outpatient practices sees about 25 to 30 patients on an average. And I've worked in urgent cares where I've seen 50 to 60 patients in a 12-hour shift. So with that being said, like with hospitalists, different organizations have different numbers of what a hospitalist provider sees as number of patients. So how does, I'm not familiar with CFIM, but like, how do you set yourself apart from other hospitalist groups out there as far as the quality or the number of patients per provider?
So again, we average about 17. We're primarily Florida Hospital, so we about 50% of our work is at Florida Hospital, another 10-15% is at Orlando Health, and then the rest is post-acute. We Florida Hospital has made it a mandate that they want 17 patients. So we're looking, that's what they want, less than 18 is that. So we're averaging about 17 there. Going back in terms of, again, the number of patients that are being seen in the outpatient, that is where we are looking at solutions. So one of the things we do is the transition visits. It pays $220. Now this is surprising. Physicians don't have time for that because that transition visits takes longer. So we're more than happy to say, listen, we'll do the transition visits, you subcontract with us and you bill for it. And why? Because that's about patient care. It's not about monetarily making money, because we can't do that with Stark and so forth. But I think that there is a huge shift towards value-based and not for fee-for-service. There are hospitalists who see 30, 35. I know many groups. Why? Financially, that's how you make it. Without the hospital support financially, it's very difficult. And as you know, nationally, the hospitalist support is about $180,000 per FTE. So that's a large amount of support for a hospitalist program. And Team Health and those have it. I mean, again, I've worked with my software company with those guys and other people nationally in the hospitalist. And supports are very high for those. So, but again, you get the quality. And one thing that you have to look at it is we physicians think Part B. Hospital thinks Part A. And when you start looking at Part A, you're looking at a different equation. If I have my own centers for a hospital, for me to pay for a hospitalist, that hospitalist needs to generate 5 lung cancers that go into my centers. Chemo, radiation, all the things that generate revenue for the hospital, it's simply a different equation. So when we start now looking, again, they're realizing that we just can't employ them, we have to incentivize them, we have to fund it, we have to have private practices and so forth, but again.
Thank you so much. We are completely out of time, but it's been well worth every second. Thank you so much. Give a big hand for our panelists today, please.
Thank you.